George Martin here from RWCS 2017. I'm a dermatologist, and I gave an update on what's new in dermatology as it applies to the rheumatologist. I focused on two areas, psoriasis and atopic dermatitis, where the introduction of biologic agents is just skyrocketing, and it's really important to keep a tab on all things biological in both areas of psoriasis and atopic dermatitis. So for those of you treating psoriatic arthritis, I'm at the other end treating psoriasis. Remember, it's a systemic disease that affects upwards of 5 million people. We have 250,000 people annually, and it's primarily a disease of individuals aged 15 to 35. But remember, about 10% of individuals are under the age of 10 who are affected by psoriasis. Sadly, psoriasis as an inflammatory disease that is systemic will decrease life expectancy by 5 years and carries the same risk as diabetes as far as cardiovascular comorbidities. Speaking of comorbidities, an increasing number of comorbidities are identified and linked to psoriasis. COPD, NASH, which is non-alcoholic hepatitis. We also find other metabolic disorders associated with it, from sexual dysfunction to renal disease. As a matter of fact, regarding renal disease, there's a twice as high likelihood that individuals with psoriasis will end up with on dialysis, and a 4 times higher likelihood that they will die of that disease. So very sad, and so keep track of their renal function as you monitor your patients with psoriasis. On the therapeutic end, we have 3 very highly effective IL-17 inhibitors. The most recent approval was for brodalumab, which is an IL-17 receptor blocker. It was just approved and has very high efficacy. It has also been, for reasons of suicidal ideation and behavior, had the black box warning applied to it, and a REMS program has been instituted for both physician, pharmacist, and patient. It may take you a while to get to the drug, but it is a highly effective drug in that class. Additionally, we have ixekizumab and secukinumab, both incredibly effective IL-17A antibodies, and we're seeing PASI 100s in the range of 40%, which is absolutely huge. So 2 very high performance drugs, both effective in psoriatic arthritis. Of course, secukinumab has been approved for psoriatic arthritis. Ixekizumab is awaiting that approval. So again, we have great therapies in the IL-17 domain. And we also have in the pipeline, and hopefully arriving this year, at least 3 IL-23 specific monoclonal antibodies. Very high performance, very highly efficacious, and they go by the names of guselkumab, which appears to be headed to market the soonest. We're seeing incredible numbers as far as PASI 90 and PASI 100s. They're in phase development for psoriatic arthritis. We have tildrakizumab, which will be hopefully out at the end of this year or early 18, and then risankizumab, which may be the biologic disruptor, with as many as 60% of patients in early phase 2 studies achieving a 1-year remission after a single either sub-Q or IV injection. So we're waiting to see how phase 3 works out. It's currently in phase 3, and so as far as the issue we talked about was tofacitinib, which has been tabled in the area of psoriasis. Tofacitinib at 10 milligrams twice daily showed in a non-inferiority study to be equally effective to high-dose etanercept in treating psoriasis and achieving a PASI 75. Unfortunately, the drug, as I mentioned, has been tabled, but further development in psoriatic arthritis will take place, and hopefully that drug will come to market either in the 5 or 10 milligram twice daily dosing range. Remember, when it is approved, both 5 and 10 milligram doses were highly effective in treating plain old psoriasis. And lastly, atopic dermatitis. There are a ton of new molecules coming into the space. We're eagerly awaiting the entrance of dupilumab, which is an IL-4 alpha receptor blocker that affects both IL-4 and IL-13, which shares that receptor. In phase 3 trials, it was shown to be highly efficacious in moderate to severe atopic dermatitis. These patients had over 50% body surface area involvement with severe disease, and we are seeing amazing results in a disease state where there are currently no approved systemic monoclonal antibodies. So dupilumab will be first in class to the market. We're eagerly awaiting it. Currently, we're treating severe atopic dermatitis with systemic agents such as cyclosporin, methotrexate, azathioprine, mycophenolate, and even IVIG. So dupilumab's entrance into the market at a dosing range between 300 milligrams sub-Q, either once a week or once every 2 weeks, will be a welcome addition to our armamentarium. And even though this disease of atopic dermatitis is primarily a pediatric disease with 60% of patients developing it before the age of 1 and 90% of patients developing it before age 5, we have to recognize that 10% of patients carry this disease through adulthood, and the disease can be quite severe and quite debilitating. And now we have a new therapy. Dupilumab is seeking approval for individuals 18 years and older, but as you might expect, trials are ongoing for younger age groups. But we expect dupilumab to come out in early 2017. Keep your eye on it. Fantastic drug. So signing off from RWCS 2017, George Martin, your token dermatologist, reporting to you live from Maui.